Good afternoon, ladies and gentlemen. Welcome to the afternoon sections of the TGMET International Workshop 2021 in the theme of Unprecedented Wheel of Complex Laparoscopic Surgery in-depth surgical video presentations. I'm Dr. Chalermchockcharoenkit, and today I'm proud to be here and to stay with us, a young, cute ladies who will present a very interesting topic about the laparoscopic pelvic floor reconstructions, Dr. Pattaya Henglasamy. First of all, I would like to introduce her to our audience. Assist Professor Pattaya Henglasamy, she is graduated MD and OBGYN from Silla Hospital, Mahidol University. Actually, because of we are a multinationality, so she has an academic DNA, not just only Thai, German, but from Australia also. So she got the academic DNA. She has an experience about the fellowship trainings in gynecologic endosurgery and urogynecology from Monash Medical Center. The DNA of Dr. Jim Saltas and Dr. Anna Rosamilia. Not finally. She also graduated from the Advanced Gynecological Endoscopic Surgery from Center for Advanced Reproductive Endosurgery by Dr. Aran Brand. So I have to recognize her professor. I cannot recognize all.
I have so many teachers.
So many teachers. So now she acts as an instructor for TGMET Center, but not at all. She also currently serves as the board of the Thai Society of Gynecologic Endoscopists. And not at all again that she is also the board of the Thai Urogynecologists Society also. So now I would like to present our warm welcome to Dr. Pattaya Henglasamy. Okay.
Thank you. Actually, Dr. Chalermchockcharoenkit is also my boss and my teacher. So I have so many teachers to help me grow, you know. So everyone has teachers in their lives, I'm pretty sure. So my topic today is laparoscopic pelvic floor reconstruction, and I'm so glad that there are so many people still left in the afternoon in this room. So this is my disclosure. So I've got no disclosure. So you can see that I graduated from here, Sirat Hospital, and I have a fellowship training in Australia, 2 locations, Melbourne and Sydney, with the 3 bosses. So we're gonna start this topic with a case presentation. And then I'll take you through how to approach and manage this case in terms of laparoscopic way. So this is a 48-year-old woman, para 1, normal vaginal delivery 18 years ago. She's sexually active, of course. She underwent, in the past, she underwent laparoscopic supracervical hysterectomy and bilateral salpingectomy due to adenomyosis and intramural myoma in April 2018. And then started to experience a protruding lump from vaginal opening and pelvic pressure 3 months after the surgery. The protruding lump became worse when she walked and did the housework. She also complained of incomplete bladder emptying and slow urine stream, needing to take more time during each void to completely empty. And that resulted in frequent urination. However, she didn't have any stress incontinence, urgency, or any urge incontinence. And she's quite healthy with no underlying medical condition. Physical examination showed previous scars from laparoscopic surgery. Just a small cervix, no mass above that cervical stump. POPQ examination reviewed stage 3 apical prolapse, stage 3 anterior prolapse, and stage 2 posterior prolapse. So it's -1 +2 +3 4 3 8 0 0 -1. So you might get confused a little bit. I will go through that POPQ examination in a few minutes. So the picture is about like that. So the cervix kind of protruding out about 3 centimeters. So now we go back to our topic. So how can we approach this case, and how could we manage this? So first of all, in terms of performing laparoscopic pelvic floor reconstruction, you really need a thorough knowledge of pelvic floor anatomy and its supportive components prior to repairing the defect. And the supportive components are composed of endopelvic fascia and the levator ani muscles. In terms of pathophysiology of the pelvic organ prolapse, I think everyone knows that it's due to the weakening or attenuation of the supportive structures. And once there is weakening, that will, it was caused by the direct trauma or either neuromuscular dysfunction or both. So once there's weakening, there'll be relaxing and damage of the levator ani muscles or the fascia or together. And there'll be opening of the pelvic floor and exposing the ligaments and the fascia directly to the high abdominal pressure. And then the ligaments and the fascia become damaged or weakened. So it's like the pelvic floor, the levator ani is like the water, and the pelvic organ is like the boat floating on the water. And the ligaments and the fascia is like the anchoring here. So once you don't have, you have the weakened or damaged pelvic floor, the levator ani, then all the tension is onto the ligaments. So in long run, it will, damage. So I think everyone knows about the levator ani, which is in this photo. So I'm not going to go deep into the anatomy of that. But I think everyone is quite confused of the fascia. So it's called endopelvic fascia. According to the Lenses levels of support, there are 3 levels. So level 1, 2, and 3 that support our pelvic organ. So the first level is what you call broad ligament, cardinal, and uterosacral ligament complex. They attach the uterus, cervix, and the upper 1/3 of the vagina to the pelvic side walls. And many will call it parametrium or upper paracarpium. The most important landmark here is the cervix, which is in the middle. And it serves as a central fusion for the endopelvic fascia, so it's called paracervical ring. So everything is fused here around the cervix. All the ligaments, uterosacral, cardinal ligaments, even the endopelvic fascia in the front, which is called the pubocervical fascia, and the fascia in the back, which is rectovaginal fascia. The uppermost part is attached to this area, which is the paracervical ring. So if there is a loss of the support, patients will end up with the apical prolapse. Could be either cervical uterine prolapse or cervical prolapse or post-hysterectomy vault prolapse. The level 2 is a pubocervical fascia and rectovaginal fascia. So they attach the middle 1/3 of the vagina laterally to the pelvic side wall, which is the arcus tendineus, and the levator fascia. So it's called the paracarpium. So the loss of the support will result in anterior and posterior compartment prolapse or cystorectocele. Level 3 is a fusion area. It's the lowest part. It's a fusion of the lower 1/3 of the vagina to the levator ani laterally, to the perineal body posteriorly, and to the urethra and the perineal membrane anteriorly. So the loss of the support will end up with perineal descent and urethral hypermobility. So come back to our patient again. So she's got like stage 3 prolapse. And how are we going to treat her? So there are ways to consider. So first you have to know what's the extent of the prolapse. What are her associated symptoms that bothering her? Her age and health status, perioperative risk, coital activity or need to have sexual intercourse, need for future childbearing, and also has she got any previously failed prolapse surgery, and of course, what's her expectation. So with that, then you can come to whether you're going to give her a conservative treatment or a surgical treatment. So let's go to the first one, the extent of the prolapse. So that's a short video about how we measure. So it's internationally accepted, recognized way of measuring. We call it POP-Q examination. So we have to measure during straining. The reference point is the hymen. So that point C is a cervix, which is the apical compartment. So that's, and then above the cervix is the demarcation line, which is the lowest part of the anterior vaginal wall. So it's point BA. And now it's a rookie area. Always that area is a bladder neck, which is point AA. So once we support that bladder neck, you can see that we can see the urethra now. Before it was kinked because of the prolapse. See, when we support it, then the urethra becomes straightened. So we measure point AA as +2. And now we go for genital hiatus and then perineal body. That's outside. And then point D, that's a posterior fornix, which is the apical portion in the back, about +5. And also the most distal part of the posterior vaginal wall is that area as well. So it's the same point, +5. Now we're going to see the posterior wall distally, which is a distal rectocele, which is the point AP. So that's about +1. So this is not our case, it's just an example. So now we're going to measure the total vaginal length. So patient don't strain. And then we report it like this, like a 9 grid, like this. And then we come to that table so we can give the staging. So in this lady is -1, +2, +3, 4, 3, 8, 0, 0, -1. So anything above the hymen is 0. Anything above the hymen is minus. Anything below the hymen is plus. So we can conclude that she's got anterior compartment prolapse stage 3, posterior compartment prolapse stage 2, and apical compartment stage 3. What is interesting about this is the anterior, which is point BA. It's just the anterior fornix. So it comes down with the apical. So once you repair the apical, the anterior will go away. Because you can see that the -1, which is the bladder neck, is already inside, so it's not prolapsing. So mainly, she's got apical prolapse. So we have to think about how are we gonna treat that apical prolapse. Now we come back to the consideration again. So first is the extent of the prolapse. Second is the associated symptoms. So apart from prolapse symptoms, she also got frequency of urination and voiding difficulty, but she's got no bowel symptoms. Anyway, all the prolapse symptoms and urinary symptoms are quite bothersome. And then although she hasn't complained of stress incontinence, but you see that she can have urethral kinking. That's why she's got voiding difficulty. So that's just a test. We call it occult stress test. So the first one I'll show you again. Once the prolapse is coming down, the urethra is kinked. So when she coughs, she won't have the leakage. But once we reduce the prolapse and ask her to cough again, you can see that there could be like a leakage, So we call it occult stress test. That's just an example. But our patients have no symptoms. So the cough stress test is negative, occult stress test is negative, and she's got quite good bladder capacity, just normal, like 400 mils. and she can void okay, with some minimal of the retention. But if she takes longer during voiding, she can mostly completely empty her bladder. We also did the urodynamic study. You don't have to pay attention to that. It's just normal urine flow, normal bladder sensation, normal bladder compliance, no USI or urodynamic stress incontinence. But we can detect a little bit of detrusor overactivity, but not that high pressure, about like 12 centimeter of water. No bladder outlet obstruction. But you can see here, maybe it's too small. During the urodynamic study, we have to put the pessary to reduce the prolapse back. So you might not see that bladder outlet obstruction. But anyway, it tells you that after we repair the prolapse, patients shouldn't have bladder outlet obstruction. And now we come back to the beginning of consideration for POP management. So now the extent of the prolapse is stage 3 and mainly apical. Associated symptoms are POP and urinary symptoms. And she's young and healthy and pre-menopause. Minimal perioperative risk because she's healthy, no underlying medical condition, and she's still sexually active. Of course, she's got no future fertility desire because she had the uterus removed already. She never underwent any failed POP surgery before, but she's got a high expectation of, doesn't accept like recurrence. So actually pessary is good too, but she's still sexually active and it's quite difficult for her to, when she have sex and remove that pessary. So she's not into that pessary, so she denied the pessary. So our plan was to go for surgery. Now, for surgery, then you have to consider whether you're going to do it vaginally or you're going to do it abdominally. So the considerations will be based on perioperative risk, present and future desire for pregnancy, coital activity, presence of dyspareunia and vaginal caliber, risk of recurrence, previous pelvic reconstructive surgery, presence of other abdominal pathology, health status, and of course, surgeon's preference. If we cannot do the laparoscopic, then we don't do laparoscopic. We might offer vaginal procedure, or we refer to someone else who can do the laparoscopic procedure. So what's good about vaginal and what's good about abdominal? So vaginal procedure is relatively safe and efficient, shorter recovery because you've got no big cut on your tummy, so it's not that painful. So most of my patients or patients at this center, they go home on day 2, postoperatively. Low postoperative morbidity, no additional skill and cost of laparoscopy, and ability to address concomitant prolapse defects and stress incontinence, ability to perform surgery under regional anesthesia apart from general. What's good about abdominal? You can, of course, get rid of all the abdominal pathology at the same time. And this is the important thing about this case, lower rate of recurrence and lower rate of dyspareunia because our patient is still sexually active. So now we think about doing the abdominal surgery. Now we have the choices, whether it's going to be open or it's going to be laparoscopic. So the advantages of laparoscopic surgery over laparotomy is reduced blood loss, direct visualization of the ureters, decreased postoperative pain, lower rates of wound complications, decreased hospital stay, and fewer adhesion formation. Oh, sorry, that just pops up. Okay. So at the end, we're thinking about the laparoscopic procedure. So before we go to the surgery, I'm going to just explain about the laparoscopic approach for apical prolapse. Remember, our patients have mainly the apical compartment prolapse. So there are 2 types. laparoscopic approach for apical prolapse, vaginal vault suspension or hysteropexy. That means if she's got no uterus, then it's going to be vaginal vault suspension. If she's got uterus, it's called hysteropexy. In this case, she's got cervix, so we can say cervicopexy. Okay. So what we can do, we could suspend it to any ligament that's available, you know. So with a vaginal vault suspension, we can suspend it to a high uterosacral ligament at the level, like higher level. Or we can use the mesh, we call it sacrocolpopexy. For hysteropexy, we can also suspend it with the uterosacral ligament. And the same, sacrohysteropexy, suspended to the presacral ligament. And also we can use a round ligament. But with the round ligament, it's not that strong. So many surgeons will do it, what we call lateral suspension, which use the mesh to help suspend the uterus. So with the high uterosacral ligament suspension, what is it? So it's a fixation between the uterosacral ligament, just posterior and medial to the ischial spine, to the ipsilateral vaginal cuff corner. So you have to find, you cannot use the insertion of the uterosacral ligament because it's already weakened and damaged. So you have to go higher to about the level of ischial spine. Okay, so that's the meaning. And from the literatures, it really provides consistent support and excellent restoration of the vaginal length, and it's a normal anatomy. You know, it's a usual anatomy of the patient. Very high success rate, 89 up to 98%. Even the vaginal procedure in our center, the success rate is more than 90%. But with the uterosacral ligament, especially vaginal approach, it's got the risk of ureteric kinking, about 1 to 11%. So that's why we need to do a cystoscopy at the end of the procedure to check for the reflux of the ureter, you know, the reflux of urine from the ureteric orifice. But with the laparoscopic surgery, if you have already identified the ureters and you see where you put the suture, you see that you're not really get into the ureter, then you don't need the cystoscopy. The second one is the sacrocolpopexy or sacrohysteropexy. So sacrocolpopexy or sacrocervicopexy is a suspension of the vaginal apex, or maybe just a part of the cervix that's left, to the sacral promontory using the intervening mesh. Sacrohysteropexy is quite the same. You have to suspend it to the cervix, because normally we don't put the mesh onto the uterus, you know, to pull it to the presacral ligament, because the cervix, as I told you before, it's the pericervical ring is very important for the support of the apex. So normally if we do the hysteropexy, we're going to put the mesh around the cervix to pull the uterus up. So it's indicated in young women with advanced prolapse, previously failed vaginal procedure, shortened vagina, of course. Like if it's so short, you cannot hang it to, you can do it with the uterosacral, but you cannot hang it with the sacrospinous ligament. So you need a bridge, you know. So that's why we need the mesh. And also, if that patient needs a concomitant abdominal surgery, then we might go for sacrocolpopexy or hysteropexy. However, if patient still has the uterus and you want to do sacrocolpopexy, then you have to remove the uterus first. Then actually it's not recommended, because there's an increased risk of mesh erosion through that opening of the vaginal cuff. So we normally keep the cervix if we want to do the mesh. So that's the example of our procedure here. But I only did like a few because it takes so long. Very tiring. So that's a sacrohysteropexy. So you have to open up the presacral sacral promontory to identify the presacral ligament. And then you open the peritoneum along the pararectal, medial to the ureter and the uterosacral ligament, into the receptum. And that's the opening of the lower uterine segment to push the bladder away and to expose the anterior surface of the cervix. And then you go laterally to the broad ligament. Now check the ureter first because we're going to puncture that area. So check the course of the ureter. We're going to puncture the broad ligament above the uterine vessel. And now we move on to the next, the left side. Check the ureter as well. So see the uterine vessel and go above it. So open the hole, put the mesh. So when this is like a T-shaped mesh. So put that around the cervix through that broad ligament. And then you have to fix it. So you suture it with the cervix. So that end the distal end will go to the upper vagina. And the two arms will come, this is underneath the uterosacral ligament. And then you suture it behind the cervix. So that will replace the pericervical ring. And then you need another mesh, actually, so you have to close it too. So you don't get like bowel obstruction after this. So close, so that's why I don't do it so often. It's so energy consuming. So you close it. Now we're going to hang it to the presacral ligament. So we use another mesh. So you suture that with the previous one at the posterior part of the cervix and the uterosacral ligament insertion. And then you close it again. Close the peritoneum. I'm on time. Okay, we're gonna just skip that. Okay, now we're gonna suture it with the presacral ligament. This area you have to use non-absorbable suture. And then you close the rest of the peritoneum, and that's the end. With this procedure, actually, it's quite good in terms of success rate and recurrence. But what is a concern of this procedure? It's like after you place the mesh behind the vagina or in front of the vagina. Sometimes patients get, we call it fibrosis area. So when you do the pelvic examination, you can get that rough area of the mesh sometimes, and that can cause dyspareunia as well. And also, if there's something happen with that uterus and you need to remove it, it's not going to be easy because there's going to be a lot of adhesion around that area. So normally I kind of spoil the patient. The patient wanted that way, so I let her have that. But you have to really do the counseling before you do the hysteropexy. So now we come back to our case. So what's going on now? So extent of the prolapse is POP stage 3, mainly apical. So symptoms are prolapse symptoms, urinary symptoms that are bothering. She's young, premenopause, and healthy. And she's got very minimal risk perioperative. sexually active, no need for childbearing. Never had any failed pop surgery before. Denied pessary. She's got high expectation, doesn't want any recurrence. Denied mesh because she's afraid of dyspareunia. And she also needs the cervix to be removed. So we thought we would go for laparoscopic high uterosacral ligament suspension. So this is a video running really no edit, mean very minimal editing. So you can see along, every procedure. So that's Australian style. We put the local infiltration. So that's from previous surgery. You can see that this flimsy uterosacral ligament, very weak. I cannot see the ovary on this side because it's got adhesion covering it. So I tried to, I decided to do the adhesiolysis first because I want to see the ureter clearly, to expose the left uterosacral ligament clearly. So here you can see techniques when you want to do the adhesiolysis. So you just see that fat plane, right? So you just cut just on to that fat, just next to that fat area. If you cut there, you're going to be in the intraperitoneum. You're not going to enter the retroperitoneum. We don't want to enter the retroperitoneum because underneath there are vessels and ureter. So if you just cut precisely at that area, you're going to be intraperitoneal. Nicely. I don't cut here, see? I know that it's attached here. So I cut here. So it's become like a flat sheet here, see? So I just want to show how to do the adhesiolysis as well. Because in urogyne, sometimes you have to repair something like after the previous hysterectomy. So you might have adhesions. So you have to know how to get rid of the adhesions to expose the area you need to see. So that's the ovary. I can see it now. But I still cannot see that ureter so well. Actually, you can see it here too, but when you want to put instrument from here to that area, sometimes it will be touching the sigmoid. So better if you move the sigmoid away from the pelvic rim. So that's why I still keep doing that adhesiolysis, because I want to move that sigmoid away from the pelvic rim. You cannot trust any instrument, you have to trust yourself. Especially in this country, we reuse a lot. You have to admit it. So we cannot be sure that there's not any leakage of the current. I'm in the wrong plane. That's accidentally entered the retroperitoneal. Have you noticed? Because you see that vessel so clear. So I changed. Go somewhere else that can see better. Now that's better now. So actually the procedure is very short, so that's why I need to put this so that it won't finish so fast. See? You just need scissor You don't need any instrument apart from bipolar and scissors. Now I can see the ureter somewhere here. So that's just a sheet of peritoneum. So I want to get it all out from the bowel. See, the ureter is vermiculating. Now done. So we can see it clear now. So now we see the ureter already. So now we can trace it to where we want. So that's the ureter. So we just open up. We have to open up the ureter. So the ureter is here. So that's the uterosacral ligament, and that's the ureter. So just want to see whether it's really stiff enough. Okay, so that's the uterosacral. So now we move to the next, the other side. So that's the ureter here. Anyway, we're gonna go faster. So we open up again. So I'm pretty sure everyone can do this. It's very easy. Except when you want to find the uterosacral. When it's very flimsy, sometimes it's very difficult to find. So you have to lateralize the ureter. So that's ureter. So down here is a uterosacral ligament. So she wants to have the cervix removed as well. So that's why we have to do cervicectomy. Anyway, we're gonna go faster so we have more time left for question. So you have to dissect the bladder away first, just to make sure that you're not gonna cut into the bladder. But she's got quite shortened cervix, so it's going to be difficult when you use the vaginal tube to delineate the fornix, because it's going to be shortened fornix. Okay, so just put the vaginal tube in. So and then we cut along this. So that's part of the uterine. So it's quite shortened fornix. So I don't want to cut too deep down because she's still sexually active. I don't want her vagina to be shortened. That's why I try to stay just exactly at the cervix, at the point where the cervix meets the vagina. Okay. Okay, let's go. Take too much time. It really takes time to remove that cervix. Okay, that's it. So now the cervix removed, and now we're going to do the suspension. So we palpate for the ischial spine, just to locate like how about where about, you know, that we should put the suture. So we brought the PDS number 0 up from the vagina. And then we suture that corner. Remember the vaginal cuff corner? Ipsilateral. And then you have to get a pull on this so there's some tension on the uterosacral ligament. Otherwise you cannot see it because it's so flimsy. And then you suture that. I don't do that spiral technique because I want to see the real uterosacral to get that thick tissue. So if you really get the tissue of the uterosacral ligament is strong enough, you don't need many sutures, just one on each side will be enough. Then you test it. Pull it, okay, it's quite strong. And then go back to the vaginal cuff, because we're gonna tie it from down below. So assistant, get it down. So we pull it, so it's gonna be about that level, see? And then we do the other side. Okay, just about time. So another OPDS. So we have to make sure that, okay, ureter is working there, working well. So vaginal cuff corner. So in terms of concept, so easy to understand, right? But in terms of dissection, there's problematic sometimes. So that's a ureter. So the uterosacral ligament is down there. So it's so close. So now you see why we have to do cystoscopy if we do it from vagina. You know, in vaginal approach, it's just a blind suturing from palpation. Okay, this is uterosacral, and then we just do the suturing. So we don't know whether we catch the ureter or not. That's why we need a cystoscopy. But from laparoscopic view, you can see clearly that we're not gonna, we haven't got any part of the ureter, so we don't need cystoscopy. So quite strong. And again, so we're gonna go fast now. It's the same as like the other side. Okay. Now we're gonna close the vaginal cuff. So just closing vaginal cuff. The good thing is when you close the vaginal cuff, you can access the pubocervical fascia in the front, and you can kind of incorporate the pubocervical fascia in the front to the back. So you cover all that apical part. So it helps with the higher cystocele. Okay, we'll close it. Take too much time now. Sorry. Okay. Now we finish with the cuff closure. We'll just use Ovicro. And now we're gonna tie it from down below. So you can see that it moves up. Move up to where we suture. And that's it, that's the end. And now you can see that the vault is well supported. Just like when you do the normal TLH. Okay. So immediate postoperative period. So the postoperative diagnosis is the apical prolapse, which is a cervical prolapse, and cystorectocele. So actually, she didn't need only the apical prolapse repair. She also needed posterior colporrhaphy. You can see that. So the operation were laparoscopic adhesiolysis, laparoscopic removal of the cervix, high uterosacral vault suspension, and posterior colporrhaphy. She recovered uneventfully. The Foley's catheter can be removed on postoperative day 1 because you see that we didn't do any anterior repair, so we're not that worried about the retention. So we just removed like normally on day 1 postoperatively. So and before she went home on day 2. Bladder capacity was 284. Post-void residual was only 20. At 6 week postoperative follow-up, everything was good. Only some minimal mucus bloody discharge. Vaginal cuff, at the vaginal cuff, it was already healed, but you can still palpate the PDS. The reason I use a PDS because it's a delayed absorbable suture. So before it become dissolved, then there would be like some adhesion, to pull that. So the repair is staying there. POP-Q was -2, -2, -7, 2, 2.5, 8, -3, and -3. So that's no prolapse. She no longer have the POP symptoms, no urinary frequency, no voiding difficulty, but some stress incontinence. Even we try to predict the stress incontinence prior to the surgery, negative urodynamic test, negative cuff stress test, but patients still had stress incontinence postoperatively, but not that disturbing. So she's not that concerned. Bladder capacity 250, post-void 16, cuff stress test negative. 15-month postoperative follow-up, everything is good. The vaginal cuff was well supported. That's still, POP-Q is still all minus. Still has some stress incontinence. But at the bladder capacity of 250, she's got a negative cuff stress test. She just came recently at the end of December last year. That's 26-month postoperative follow-up. Everything's still good. However, we recognize that she's like 50, 51. So her mucosa is getting thin. And we did it's my habit to check the ovaries for the patient if I keep the ovary for them. So I did the transrectal ultrasound so we can see the vaginal cuff very clear. And the transrectal ultrasound can go higher than the vaginal cuff. So you can see the ovaries better. So she's got smaller size of the ovaries now, but she still she didn't have any menopausal symptom. POP-Q examination was still very good. She still had that stress incontinence. You can see that with the bladder capacity higher, 400 mils, cuff stress test became positive. But anyway, she's not concerned. So she's happy, very, very happy at the moment. And so in conclusion, to choose the right treatment strategy for pelvic organ prolapse, one should take into consideration the location and degree of the prolapse, troublesome symptoms, concurrent pelvic pathology, individual patient sexual and reproductive activity, expected outcomes, and overall health status. By offering several treatment alternatives, either vaginal, abdominal, laparoscopic, even nodes, natural orifice, clinician can help to ensure that the largest number of symptomatic women achieves their personal goals. So if we know, if we have, it's like we have more options for our patients, so to get better surgical outcomes. So thank you very much.
I think that now
so we have 12 minutes.
Yes, we have about 10 minutes left, no? And I think that now everyone in this room, or for all audience that agree with me that we are proud to stay with the young, fantastic ladies surgeons with the video of the fantastic operations. I think that for the urogynecologists now, the knowledge about that is more complicated. So to give the better treatment, so something have to be done like more investigations, and especially for the complicated opinion,
Yeah.
which part should be treated, which part should be affected. Right now, I think that if all of the audience know about the pubocervical rings, you can see that in the operations now, even for the TRH by Dr. Amphan. Dr. Amphan and also for Dr. Pattaya will
We'll do the
suturing
suspension, yeah.
for the suspension or to suturing anteriorly for the endopelvic fascia
Yes,
anteriorly and posteriorly to prevent the consequence, the bad consequence like this. And to do like this. Okay, maybe can I ask you some questions?
Yes, sure.
Okay, I think that two things. One is that for my opinions, maybe if you do the cervicopexy, not to cut,
Not to remove the
not to
cervix.
remove cervix,
Yeah.
maybe it may be more easier. One,
Yeah, I think
so
so.
why do you cut the cervix out? Okay, and the second, how can we be sure that the tissue that you glasses is a uterosacral ligaments? Because of if I from the operation I can see that beneath the ureter, and we have to aware about the uterine artery or internal artery that beneath the ureter, and you glass the tissue like that. Okay. Thank you.
So the first question, why do we need to remove the cervix? No, we don't. Actually, it was the patient's preference to get the cervix removed. But in my opinion, if you don't want to remove the cervix, let's say Prof. Karakot usually does a lot of subtotal hysterectomy, right? So if you can recognize that there's some weakening of that uterosacral, you can just plicate that uterosacral ligament so that it becomes stronger. Just at the insertion, but you have to kind of suture from higher, at the high level, and then to that insertion point at the cervix, and then once you tie it, it will be well supported. So you can do that as well. But sometimes it's quite difficult to see all the defect around the cervix. So that's why I tend to prefer remove the cervix, so I can see around like 360 degrees around the cervix to see all the fascia in the front and the fascia in the back, all that pericervical region. So I can repair, kind of get rid of all that upper compartment prolapse at the same time. And the second question, how to identify the uterosacral ligament. You can see that I try to find it first. You cannot remove the cervix first and do it. It's going to be too difficult. So, because you need some tension, because it's very flimsy. So I get the Alice clamp to hold that cervical lip, push it in, just like you antivert the uterus. So you get the tension on the uterosacral, that flimsy uterosacral. So you get that lining a little bit where it is, the trace of the uterosacral. And then when you dissect underneath the peritoneum, you will see the fiber of the uterosacral ligament. Then you know that it's a uterosacral ligament. But of course, nearby there are so many vessels. Sometimes we get bleeding. But once you tie, it normally stops. Yes.
So now we can get not just only a one trip, but many tips from our speaker now.
Yes.
So I think that even for me,
Dr.
I can
Amphan.
bring this to improve myself.
Okay, first of all, I would like to congratulations for your work and also for your nice presentation and video presentation. It's very clear, and I think anyone sitting here understand what you like to tell us by your presentation. So it's the same. What the first I ask is like Professor Karakot argue that why we have to cut the cervix. Maybe it's more easier to do, but if the intention from the patient is okay, no? But if no intention, maybe it's much more easier to do that.
Easier.
And also the second one is I saw the vaginal cup, TGMET vaginal cup. So it's my good also
nice,
if you choose the cup that is equally the size of the cervix, so you can push up and can make it easier to gaps or something like that. Maybe better than spun because from the slip to the anterior to the posterior or something like that.
Actually, we use the vaginal tube, but it's kind of reused many times. so the edge is like rough, you know.
But it can quite equally to push up. No? If you use a span, maybe it's slip to the anterior to the posterior or something.
Yeah.
Okay, and the another one what I like to argue that is the suture material. What you use is a
PDS.
PDS. It's not monosin, no?
No,
it's PDS.
PDS dissolves later.
It's later. You need longer, no?
Yeah.
And another one is why you don't make a suture, like make a knot. You pull to the vagina, right?
Yeah.
And you make a knot. But for me, I think it's maybe can make a knot inside, both sides.
The reason I forgot to tell you.
Yeah.
If you tie it first, then it's gonna be so high. When I want to do a vaginal operation, I will get into trouble because everything is so high and deep inside. So I have to tie it at the end. So that
But
was
you
at the
can
end.
you can tie the end.
I did that at the end. So
no.
after I do that suturing already, I leave
Yes.
it. And then I go down. I went down to the vaginal and do the repair. The anterior repair, posterior repair.
Oh, you do more.
Yes.
Understand.
Because sometimes you need that. If it's so high, you cannot really get access to the defect.
Understand. I think we don't know that you do anterior and posterior couple cup last year also.
After I have repaired everything, then I tie that knot.
Okay, understand.
That's why it has to be in the vagina. But the bad thing is that it's a delay absorbable suture. So like 2 months, 3 months, the PDS is still there.
That is mean why I don't like to use a V-lock in the first layer of the vaginal valve closure. It's similar.
Like forever.
Take time.
Yeah.
And maybe it got spotting or some discharge a little bit or something. And make our patient is worried. No? If we use a YQ, just 6 weeks or 8 weeks is already no more YQ and the wound is clear. No?
Yeah.
Okay, thank you so much, Professor Pattaya.
Oh, Professor Pongsak. Don't ask difficult questions.
Thank you very much for your
We have
very
3
beautiful
minutes left.
presentation and video. I would wonder for one question that could we hang the apex of the stem to the promontory of cecum or no?
You mean this
Hang
in this
up,
case?
yeah, yes.
No,
Why not?
she's got only like 8 centimeter of the vagina, so it's too high.
Too high.
Too high. And if you try to pull it there, of course you can do, but then there's going to be too much tension. There might be some cut through happening. So you need a bridge. So you need to use mesh.
Yeah, I mean a bridge.
Yeah, you can do it. So
Yeah.
it's going to be a sacrocolpopexy,
Yeah.
not the uterosacral suspension.
Okay, thank you.
All right. So
Actually,
we've done
for
well.
me, for the last 5 or 10, nearly 10 years, that at the time to do the pre-sacrocolpopexy is more popular. But when the time passes, I think that the more fantastic operations occur like this.
Actually, it's like in this time, we call it anti-mesh era.
Anti-mesh.
So that's why
Anti-mesh
we try not to use mesh.
Yes.
And I can see, actually, after having done a lot of urogyne case, I've seen that if you really know where the defect is and you can repair it completely, I think native tissue repair is okay.
It's the best. Yes. Okay.
All right.
Maybe now
I think it's
we
time.
can Okay.
If I'm just reading. They just know. Do you use monocryl? Monocryl dissolves quickly, quicker than the PDS. So I might use the monocryl for closure of the vaginal cuff, but not for the uterosacral suspension.
Can I ask the last questions?
Yeah.
If do like Dr. Amphan comments, by tying knot inside the abdomen, not through the vagina, can we use the like a non-absorbable material for suspension?
Yeah,
Any
but then you
comments?
cannot enter the vagina.
Yes. Also, we can use but not enter the vagina.
But it's going to be very difficult because our patients are most of them are old. They've got a thin vagina.
Thin vagina.
Then there's going to be cutting through. So better do a full thickness. So that's why we need a delay absorbable.
Okay, so we have to choose better to choose a delay absorbable.
Yeah.
Yes. Thank you very
Alright.
much.
Okay.
If any questions
Yeah,
more,
thumbs up.
I have to say thank you again for our cute
Pleasure,
prisoner
pleasure.
and for the